Hello, this is Jim Crawford, the moderator for this month's webinar. This is the PCPCC Center for Health Information Adoption and Exchange, the CEHIA, monthly webinar series. Today's webinar, we have the pleasure of Dr. David Kibbe presenting on meaningful connections, supporting patient-centered medical care through connected health information technology. A couple of housekeeping comments before we get started. This session will be recorded, and the whole presentation with slides should be available on the web by the end of this week or early next week. You will be able to find this presentation at www.pcpcc.net/media. Again, www.pcpcc.net/media. During the course of this presentation, if you have questions on the right side of your computer screen, you'll be able to click on questions, type in a question. If they are technical, our webinar technical support will answer them. Questions directed towards the speaker, I will queue up, and what we hope is about a 15-minute Q&A period at the end. I will feed those to Dr. Kibbe. I want to alert you to our February 10th webinar, 1 to 2 p.m., which will be a case study of HIT integration in the Adirondack Medical Home Pilot Project. It's co-sponsored by CMD and will feature Drs. John Ruggie, Dennis Weaver, and Cynthia Nasavera. I also want to alert you to the spring PCPCC stakeholder meeting in Washington on March 30th, 2011. And two more things. First is the fact that if you go to the pcpcc.net webpage and track down our center, the CEHIA, you will be able to get PDF copies of our most recent white papers, Transforming Patient Engagement, HIT and the Patient-Centered Medical Home, and Clinical Decision Support and the Medical Home. And lastly, as we get to the end of the presentation, just before our Q&A, I will feed to you a quick poll that you can provide some feedback on your current HIT status. So, to introduce Dr. Kibbe, he is a well-known individual in health information technology in the medical home world. He's senior advisor to the American Academy of the Family of Physicians, chair of the ASTH International E31 Technical Committee on Healthcare Informatics, and principal for the Kibbe Group. He has a long and illustrious record of service to the community in regards to health information technology, both to institutions, firms, and central agencies. So, David, we look forward to hearing you speak.
Thank you, Jim, and thank you the audience for the opportunity to present today and to bring you some of my thoughts about the acquisition and use of health IT in what is really increasingly a rapidly changing world and environment. What I'd like to do today is to show how our ideas of health IT are shifting from practice and enterprise-based systems increasingly to patient-centeredness, while at the same time we're being challenged to rethink health IT in light of healthcare organizations and regulations, payment reform, which puts providers and their organizations at financial risk. This is creating a fertile ground for innovation in health IT and new opportunities for providers to improve patient-centeredness and also be able to manage financial risk. However, the concern I have is that many providers and newly forming provider organizations aren't bringing the necessary insights about risk to their health IT purchasing decisions. So I want to end up today with some very concrete recommendations about both patient-centeredness and risk managing health IT. I'm going to assume that this audience, which is in the past I've addressed several times and is quite sophisticated, that you already know a good deal of basic information about patient-centered medical homes and accountable care organizations, and I won't be covering this material. I also will attempt very hard not to mention any vendors or any brand names. So let me start by a brief look at some recent policy and professional prescriptions for health IT and patient-centeredness. Travel back in time to mid-2009, about the time that the patient-centered Primary Care Collaborative was being organized. Given that most electronic medical record systems in the past have been practice-centric, not patient-centered, I began writing about the capabilities and tasks of health IT that would support patient-centeredness, excuse me, rather than simply features and functions of electronic medical records. I wanted to get away from the box that we had created for EMRs and the connotations that these were tools to manage within the four walls of the practice or enterprise. But that really didn't include what I thought was very important, which was, for example, provider communications across boundaries, or interaction directly with patients, or measurement of quality. And so these abilities that you see here, and I won't read to you, appeared in the body of Meaningful Connections, which was the first PCPCC publication on electronic health records. NCQA accreditation and recognition standards for the patient-centered medical home are another prescription for patient-centeredness. They imply the use of health IT, but they don't specifically mention electronic health records or EMRs. If you look at this list, I think you can see very clearly that it would be very, very difficult to do this without electronic health records. And of course, the new OMC CMS regulations subsequent to RF High-Tech that set up the EHR incentive programs have pretty much completely redefined EHR technology in terms of meaningful use. Certification of EHR technology, and I just looked, there are now over 215 EHR technologies that have been certified by OMC. Describes the enabling features of an EHR relative to specific components and activities deemed meaningful to quality, coordination, and transparency of care processes. Now, while not explicitly patient-centered, it can be argued that there is now a distinction between the older electronic medical record functions that were payment and reimbursement driven and a new set of tasks EHRs are required to perform. And I think it's fair to say that meaningful use is patient-friendly by comparison with the older technology specifications, for example, the C-CHIP certification criteria circa 2008. Measurement features importantly among the tasks that EHR technology must perform under meaningful use. And it's very interesting to notice how a modular approach has been accommodated within the regulatory framework, as well as how quickly the market has responded with modular products, many of which are now web-based or internet-based. And what this slide does, if you haven't seen this before, is to sort of begin to map out how modular components of electronic health record technology could be used and assembled by users in order to meet the requirements for meaningful use without having to buy all of these necessarily from the same single vendor. Now, if we take a peek forward, we can see that meaningful use objectives and measures for stages 2 and 3 will increasingly stress patient engagement, care coordination, and health data exchanges. So, for example, in the NPRM, which will be released, I believe, this week or next, there is a requirement that providers connect electronically with referral and referring physicians on a regular basis. That will be 3 providers in Stage 2, 2013 meaningful use requirements, but it will be 30% of the primary referral network by Stage 3. In addition, increasingly patients must be offered secure patient messaging online. So, if I summarize what policy and medical professionals see as the ideal of patient-centered health IT, it really boils down to these 3 uses of health IT: encouraging, enabling patient participation and engagement in care, the ability to coordinate care across organizational boundaries and across time, and measuring of quality, effectiveness, and efficiency of care in order to continuously improve the patient's experience. And I think these are all fine and good, but they are, at this point, prescriptive as opposed to reality-based. So let's step back and consider the environment we're in right now with respect to the costs of healthcare. And these costs are just simply unsustainable. The crisis is already upon us and it's getting worse every day. The waste in the system is incredibly, accounting for about 30 to 50% of every healthcare dollar spent. And the kind of growth in healthcare spending pictured here and in the next slide are just catastrophic to the well-being of the economy. I heard former President Clinton speak about this at a meeting not too long ago, and he compared our country's economic viability with respect to global economy. And he said, you know, our companies start off with an $800 billion deficit because they have to pay that for healthcare above and beyond what other industrialized democracies and the emerging economies have to spend. So, you know, we just don't see healthcare costs. We just won't see the healthcare costs, the income of doctors, hospitals, pharmaceuticals, medical devices, and so forth, account for 30% of the gross domestic product, as is indicated by this slide, could happen as early as 2028. This is just not going to happen. Some things are going to intervene. Some things are going to happen. And if we take, for example, hospital readmissions, which studies have shown occur for approximately 20% of all Medicare hospitalized patients within 30 days of admission and account for almost $20 billion, the thing that is going to happen is that Medicare is simply going to stop paying for the care of patients with certain diagnoses who are readmitted within certain time periods. So, for example, beginning October 1 in 2012, DRG payments to hospitals will be reduced if they have excess readmissions. There are 3 conditions that will be tracked initially, and that list will rapidly expand. There's another thing that's happening, and that is 2 new models of care delivery have emerged designed to do a better job of managing both care quality and care costs. And these are the patient-centered medical home and the accountable care organization. And I think that you know in this audience that the patient-centered home is increasingly being seen as dependent on and complementary to the accountable care organization as a way of managing populations of patients. Now, I think we're in transition. Most of us truly welcome these changes, but to be honest, we're also ambivalent. We're in between. Witness these quotations from 2 different medical directors. The first one who says, well, we're still trying to do as many procedures as possible. Of course, that's because what they get paid for. But we're thinking about cutting down on those that are unnecessary. An amazing statement. One that makes me laugh, but also makes me realize that, you know we're doing unnecessary stuff, but we keep doing it. The other is also, I think, meaningful in the sense that it recognizes that the board of in this particular group is very supportive, but they won't allow me to lead our organization into bankruptcy by doing the right thing. So somehow or other, we're now in between being paid for volume and being paid for value. The big idea here is accountability. But that's just another way, in my mind, of saying financial risk. These new models, in combinations with limits on spending and limits on benefits packages, are a means of shifting more of the financial risk of healthcare spending onto the providers and provider organizations. It's plain and simple. What isn't so simple is what we mean by risk. And I show you this slide here to illustrate what is a rather conventional thinking about what risk looks like to providers. Risk can be deep or shallow. It can be narrow or wide, and it really doesn't affect doctors in patient-centered medical homes or accountable care organizations early or with much impact until somewhere around 2014 and 2015. I think it's particularly naive and short-sighted to think that patient-centered medical homes and doctors in them are not going to be exposed to financial risk. And this is why. Excuse me. This slide got, there we go. The reason why is that I think risk to patient-centered medical homes and to provider organizations in general can come in a lot of different forms. And it doesn't relate only to patients who are capitated. So for example, if payments are reduced per episode of care, or more of your patients are underinsured or uninsured, or if payment bonuses are tied to quality metrics, which incidentally cost money to put in place and sustain, or cost shifting is no longer an option. All of these situations mean that providers have fewer resources to provide the same or higher levels of service. And that means that risk is shifting to the providers. I think that regardless of how fast we move towards capitation, these risk factors have to be taken into consideration. And to my way of thinking, this really does provide us a new lens through which to consider the acquisition and uses of health IT. I think there are certain uses of health IT that are very consistent with managing provider risk. And these I have placed in the column to the far left. It's light blue. So member engagement, cross-continuum medical management, clinical information exchange, quality reporting, very importantly, business intelligence and risk and revenue management, which in many situations is the same as actuarial risk, are those uses of health IT that I think are specifically useful for managing provider risk. And they're going to change and mature over time as the organizations mature. So for example, if you think about clinical information exchange, early on, you may have very static or read-only access to health information, the kind of clinical information exchange that is available in some health information exchanges. But over time, that has to be pushed along the care flow continuum so that real-time sharing of information is possible for providers and other professionals who are taking care of patients. Similarly, if you look at business intelligence, it may early on be based on encounters or very focused data around billing, but in time, this needs to shift to whole populations of patients so that calculations could be made about the risk of patients across a continuum of care, not just a single episode of care. So, what does this mean? As I think this through, I think there are four specific imperatives that combine patient-centeredness and provide risk management simultaneously. So if I am advising a healthcare organization, whether it's a patient-centered medical home or an accountable care organization, to think about what they need to do, these are the top four for me. The first is to move their architectures and platforms to the web and internet, mobile platforms. I'll explain more about why that's important in a minute. The second is to provide cross-boundary transport and communications so that these are possible anywhere, anytime. The third is to accelerate the technical interoperability and computability of data between systems. And the last is to make cost accounting patient-centered, measuring shared costs of care around patients' care cycles, not around departments or divisions, etc. The reasons I think that these four are at the top of my list have a lot to do with the cost of information technology itself. The scale of web-based cloud platforms lowers the cost of ownership, makes it easier to use, and allows the data to be repurposed and patient accessible. Transport layer openness removes a lot of the problems associated with multi-organizational teams working and can encourage the use of clinical groupware to redefine workflows. Without data liquidity, which is another way of describing interoperability of data sets between different systems, we can't drive analytics for continuous improvement. It becomes very, very expensive. And then measuring the value of the healthcare processes can reprioritize patient experiences over time, greater than 1 year. I think we're going to find that the organizations that use information technology successfully in the next few years are those that can move very quickly and can learn quickly. Obviously, there's a lot more that I could say about these things, but perhaps that's another talk. What I'd like to do now, in the next 10 or 15 minutes, is talk about the bright side of things. I think in some ways this is sort of a grim message, but the innovations are out there that can help us to get there. Things are happening and are available and are being adapted into healthcare from outside healthcare in a very fast clip, driven by the changes that the administration is making in the health information technology marketplace. Yesterday, Health Affairs blog published a piece that Brian Klepper and I have written about unfreezing the health information technology markets. If you blog Health Affairs Kibbe blog, it'll come up and you can read that article and see a little more deeply what I'm talking about. But I want to go through just 4 of these very quickly so that you'll have an idea of sort of what are the meat of the bones that I'm talking about. The first is the cloud as architecture for collaboration. Secondly are this idea, this notion of modular and increasingly mobile plug-and-play EHR technologies. The third is simple, secure internet-based transport, which has been given a big boost by the Direct project. And then finally, just to say a couple words about universal exchange language and XML. So if we think about cloud computing, most of us are already there. These 10-year commuting cycles are important. We are now in one that is increasingly seeing mobile computing to become the standard. We're accessing the internet on the web, but we're also accessing the internet through these devices. Platforms and applications have moved to the cloud. So whereas the platforms and apps ran in the 1960s on mainframe computers, and in the 1980s they worked on client-server applications, in situations now, much of the computing done for industry, for e-commerce, for banking, and starting very soon for healthcare is done on cloud computing platforms where the servers are located somewhere connected to the internet and accessible through the internet. We all know this. We just are not familiar with it in healthcare yet. One of the important consequences of this is that collaboration now moves to the cloud, or is capable of moving to the cloud, so that at least the opportunity or potential is there for multiple teams of individuals managing patients who cross organizational boundaries to work together. If you use Twitter or Facebook, your communications over those collaborative tools may be occurring in multiple organizations, in multiple homes, and multiple machines that you're really not aware of because they are capable of reaching through those institutional boundaries. And I think this is one of the big, big things that is important as you think about your organization being able to collaborate with people who are in other organizations. How can we do this without having to sign on 15 different times, for example, right? And how do we do this without the organizations walling off their networks? Part of what's happening, of course, is that we have the technology available to us in terms of these new tools like smartphones and iPads and other new technologies which are easily carried, and which are essentially supercomputers in our back pockets because of their ability to access the wide range of meshed, server-delivered information and computation out in the cloud. The medical app store will be here. I'm just not sure whether it's going to be 2011 or 2013. Interesting that there are now more cell phones than desktop computers in the United States. And the sale, that doesn't even include the sale of these tablet PCs like the iPad. It's thought that there may be as many as 30 million tablet sales in 2011. So this mobile revolution is well underway. Physicians and other healthcare professionals who are not allowed to use their cell phones or their iPads in the hospital are really being impeded in terms of their ability to practice good medicine. ONC certification has tripled the numbers of electronic health records, many of which are internet-based. I think this is a very interesting, evolving situation. I mentioned it in the health affair blog piece that Brian Klepper and I had published yesterday, but approximately 150 of the 200 plus EHR technologies that have been certified are either complete or EHR modules for ambulatory care. And about half of these, to my count, are cloud-based, both web-based and internet-based. In other words, they work in HTML environment as well as on smartphones. The costs have markedly decreased. We are seeing the costs of electronic health record technology at a real fraction, an order of magnitude less now than it was just a year or two ago. The next innovation, I think, has to do with simple internet-based data transport. And for many of you, you have some familiarity with the direct project protocols and specifications to connect physicians. If you haven't heard about the direct project, I encourage you to go to directproject.org and learn about it. This is a really very important public-private initiative that in the last year involved over 400 different organizations and was dedicated to making it possible for physicians to easily communicate with other physicians over the internet, to do so securely, and it has generated a fair amount of new technology, which is all open source. This is really the problem that I think the direct project is meant to solve. And interestingly, just a few days ago, there was a journal article published which showed that roughly 35 to 40% of referring physicians never receive the referred materials that are faxed or mailed to them by primary care physicians. We need to make it easy, affordable for physicians to communicate with one another. I call this colleaguing, just like Facebook calls it friending. I want my colleagues to be able to communicate with me securely, electronically, without having to do the fax. The context for this is interesting. There are really three mechanisms for health data transport right now. Of course, still the most common one is fax, mail, and courier. But we also have enterprise-wide networks. Almost every hospital or hospital system has its own private network. And then there are a growing number of health information exchanges out there that bridge across multiple hospital systems in general. This is very interesting quote by John Halamka, who I think many of you know, the CIO at Harvard Health System, and why we need a fourth transport system. And the reason really is that there are so many small practices in the United States that aren't connected to any of the other mechanisms. These small practices, John says, should not have to operate servers or have to pay for a complex health information exchange infrastructure. Healthcare information service providers, which are called HISPs, should provide them the means to exchange data as easily as Google provides Gmail or Verizon, FIOS provides ISP service. And I think that's one of the things in 2011 that will explode into the healthcare world, make a big difference, make it much less complicated and much less expensive for many physicians to move data to other physicians and to their patients, and do so in a way that will fulfill some of their meaningful use objectives for stage 1 and more in stage 2 and 3. This is a description of the innovation of the direct project. It really involves cross-network transport that's vendor neutral and uses open protocols so that any sender on the left can push a message through a health information service provider, very similar to the way that you and I push email to anyone else whose name, email address we know. The sender's HISP receives and then moves the message to the receiver as long as he or she has a direct address and has the necessary security protocols in place. So to summarize, direct project and direct compliant networks are simple, secure, vendor neutral, and effectively create point-to-point email with attachments. Finally, I want to say a little bit about accelerating interoperability. Here the President is seen looking at the PCAST report that was published on December 8th. PCAST is the President's Council on Science and Technology. This is a very important document. I would encourage everybody to read it. What it really says is that the federal government's got to get really, really serious about using extensible markup language and other modern languages that allow data and metadata to be interoperable across systems and computable. The PCAST report recommends the establishment of a universal exchange language in XML and envisions metadata tagged data elements that are web searchable, able to be assembled by providers and patients. The paradigm here is one that is very similar to Google and Bing and other search engines, being able, within a secure environment now, to locate and assemble information that has been tagged and has carrying these metadata elements that identify the patient, determine where the information was generated, and also carry a specific consent management metadata about where the patient will allow the data to be seen and by whom. Interestingly, the PCAST report was also very highly critical of centralized database efforts like the HIEs. One of the, I think, important research efforts that is underway that is related to this effort to make healthcare data more liquid, be able to move it between systems and out of data islands so that it be acted upon for the improvement of quality, for decision support, and for research, is a program that is a research program based in Boston Children's Hospital. Ken Mandel and Isaac Kohani are the two physician leaders of this program. It's called the SMART Project. SMART stands for Substitutable Medical Applications and Reusable Technology. The idea here is really to create an iPhone-like app store for medical applications that are substitutable. You know, in the same way that if you have an iPhone or you have an Android-based smartphone, and you want an application for, let's say, something as simple as a compass, or as complicated as managing your cardiovascular workouts. You simply go to the App Store, you see how much the application costs, many of those are free, and you download it. And if it is a good application, as most of them are, it will integrate with other applications, and it will use information about you and about your friends and about satellites up in the sky, and will help you do something that's useful, like locate a restaurant or locate a doctor or find your way around a city in which you have little familiarity. There's no reason why we can't allow electronic health records, make it possible for electronic health record technology to offer up to other electronic health record technologies data and information so that that information can be reused, and we would thereby stimulate an ecosystem of companies whose products would increasingly add value to that information right now, we're sort of locked out. So, am I missing anything? Well, of course. I'm probably missing a lot of things. But I hope by, first of all, giving you an idea of where I think the professions and the policy prescriptions around patient-centeredness have been going, and then pointing out that this isn't enough, that we also have to think as we make decisions about the acquisition and uses of information technology, that increasingly those provider organizations are being asked, and in some cases demanded, that they take more of the financial risk of the society's care of our populations. That this really does demand we think about the decisions we're making with some different and new insights. As daunting a challenge as that is, and I can tell you that I touch a lot of organizations that really haven't even thought about something as simple as intra-organizational communications between doctors. As daunting as those problems are, the changes that are occurring in information technology, some of which are being pushed along fairly aggressively by the current administration, by Health and Human Services and ONC, I think are making it increasingly likely that provider organizations can be successful in making this transition and using information technology in new and exciting ways to both manage patient risk, provider risk, and to do this in a very patient-centered way. As a matter of fact, I think patient-centeredness is absolutely key to managing the risk that providers are going to be increasingly placed under. I would be glad to entertain any questions at this point, and you have my email here. I'd be delighted to speak with or email with you at any time. Thank you.
Thank you, David. This is Jim Crawford, the moderator again, and for those of you who tuned in after we got underway, the content of this talk, both recording as well as a PDF version of the presentation slides, will be available either at the end of this week or early next week at www.pcpcc.net/media. Again, www.pcpcc.net/media. Now, right now I'm going to try something I haven't done before, which is to push out to you 2 poll questions. You should now have up on your screen a poll question: what point are you in your journey to become a patient-centered medical home practice? And I'll give you a few seconds to click on one or the other. So hang on a moment. The numbers indicate that most of the answers are in. Okay, so now I will close this and I will push out the second poll question, which is, okay, at launch, right? Okay, so how has this webinar helped better your understanding of how HIT supports better patient-centered medical care? And for those of you who are wondering, the first poll question was 89% of you just starting the journey are not applicable, and then an even split of about 5 and 5% for NCQA3 or 1 or 2. For this one, Dr. Kibbe will be pleased that the responses are favorable. So I will close this. There were actually only 2 questions that came in over the course of the talk, David, but not to worry, I've got a couple myself. First question is, when will the regulations and can't read my own handwriting, privacy of wellness services specified in the Health Reform Act, boy, let me go back to the question because I can't even read my own handwriting. Hang on a second. Right. When will the regulations and pricing, thank you, of wellness services specified in the Health Reform Act to be covered for Medicare patients with no copays be available? There is a fear among primary care physicians that if reimbursement is too low, it will reduce the frequency of services rather than increase them. So regulation and
yes, right. Well, there are a couple things that go into effect in 2011 with respect to the Health Reform Act. One of them is that primary care physicians are going to get a 10% increase in their fee structure from Medicare, which is good. I think many people think that's not enough, and it's too late. The other is that Medicare beneficiaries are given the options to have some preventive care services, including an annual physical examination, without a copay. And I think your question is when is the pricing for those going to be announced? And quite frankly, I don't know. I would imagine it would be fairly soon. Of course, all physicians are facing a potential 26.5%, I think, cut across the board from Medicare as of January of 2012. I think you all know that the 25% cut was postponed once again for the 5th time in 2010. But I don't know exactly when those fee decisions are going to be made.
David, the second question, the article mentioned in reference to referrals. What is the title? Maybe it's possible to do an email correspondence. Just off the top of your head, you'd mentioned.
I don't know. It was published recently. It was mentioned in the Wall Street Journal blog yesterday. I don't want to guess where it was published, but I glanced at it and read the results. Maybe we can find that out and include it as a slide when we convert these to PDF.
So David, question I have is the relationship of the cloud EMR to the infrastructure of physician performance. Going back 2 years, one of the concerns I had was that deploying practice-based EMRs was all well and good, but that it was going to be very difficult to run both the data aggregation and the analytics on whether physician practices were performing up to whatever new standards there may be. And the concept that the EMR environment may actually be moving into a client-light, cloud-heavy environment raises the question of whether the infrastructure for practice management and assessment could also, in essence, be a virtual event as opposed to individual practices having to hire individual vendors to help them assess their own performance. And how do you see the two relating one to another?
Well, I certainly think that there are already a number of vendors out there who have made the entire claims and billing cycle a service so that the practices essentially outsource the revenue cycle to those companies. And a couple of them are quite well known. I think it is predominantly remains the case that medical practices continue to have their billing and claims applications in-house, generally speaking, on the premises. I think that over time we're going to see more and more of those medical practices understand that it's a lot less expensive, A, to move the computing part of that into the cloud while the data entry part remains inside the practice. And secondly, that allows those organizations that are good at this to increase collections, to decrease the time that collections are in accounts receivable, and to perhaps even more importantly provide information back to the practice that is benchmarked against other kinds of practices. this is a there are still something like 1,500, maybe even 2,000 billing programs out there. It's a revolution waiting to happen, and it's always amazed me why it hasn't happened faster. I've been in practices that have 15% of their revenue going to billing and claims, and hire 5 or 6 people when they could be having 6% or 7% devoted to that, and of course that would be a 6% increase in revenue, in net revenue in a single year, and they really hesitate making that decision. I think it's interesting that we'll probably see doctors more readily accept software as a service and cloud-based computing for electronic health records initially than they will for their billing systems.
Okay, and actually we'll have to move into a quicker mode because a whole bunch of questions have now come in, and I'll just take them in order. Please talk to the difference between so this will be sort of rapid fire. Please talk to the difference between the use of discrete and non-discrete data.
Well, when people talk about discrete data, they're usually talking about data that is not text, data that is able to be encoded, data that it can go in easily into a standard database.
Is the current emphasis on developing HIEs misplaced? It would seem that the HISP decentralized model would win out ultimately. Should we keep leapfrog ahead to HISP development?
That's a very good question. It's, of course, politically charged. I think there's a lot of debate right now about whether or not health information exchanges are old technology or new technology or some combination of both. I don't have a really good answer to that. I think we'll find that many of the HIEs do not survive their planning budgetary periods. On the other hand, there will be some that will do very well, and I think it will likely be because they adapt and they change from being large data repository efforts to efforts to locate records and get them where they need to be at a very low cost to the providers.
Do you think that XML, which is tag metadata, needs to support semantic interoperability as through the use of controlled medical vocabularies?
Yeah, I think the part of the problem here is that we have several different controlled vocabularies that are in current use. The real key there is whenever we use a standard like the continuity of care record or the CDA-CCD or what comes next, that we are very specific with regards to what vocabularies may be used and are acceptable, because otherwise you can't. One computer is talking French and the other computer is talking German. There are translator methodologies out there. I think everybody knows that there's the universal medical language vocabularies, but they don't translate very well. So the answer is we've just got to be very specific as to which vocabularies are used. That's called profiling. The way that Google uses the CCR is to require that ICD-9 be used for coding for problems, for example.
Another frame of reference, in the ACO model, is the payer a part of the ACO as an entity, or does the ACO contract with the payer?
That's a terrific question. I think that it's a mistake for a lot of people to, well, the answer is both are going to happen. Larger ACOs are much more likely to in-house their health plan components if they can. I think it's just beginning to dawn on health plans that they can actually serve that function for ACOs. Somehow or other, though, ACOs that are going to be successful are going to have actuarial talent, actuarial skills, actuarial tools. You're just not going to be able to be a successful ACO of any size without those. And in different parts of the country, for different reasons, I think both models will evolve.
Yeah, and shared risk is a term that I've heard come up in this context. How do you see tablet computers enhancing patient-centered care, and when?
Well, I think they already are starting to. I think they enhance patient-centered care in just a lot of different ways. One is they allow the provider as well as the patient to be connected and to be more aware of what's going on. I think that these tablet PCs are brilliant in terms of their ability to display information. I was just at a radiological conference in Washington this week, and the radiologists are talking about the extent to which these tablet PCs can display at a very, very high resolution, essentially clinically diagnostic images. So those are a few. I think probably the most important thing about all of this technology is that patients are already online. They're pretty much waiting for their doctors to be.
There's a quotable. What technologies do you see as core for ACOs, and what is your prediction about the viability of ACOs?
Well, that's really what I was trying to do in this talk. I think if you go back to that slide where I'm trying to lay down, four imperatives with respect to information technology for ACOs and for provider organizations in general that are going to be assuming risk. Those things are all important. They're all important, and they're all moving targets. That's the other thing. I think the viability of ACOs is terrific. I mean, I think there are going to be ACOs that are very, very successful. I think it's partly going to be because of the culture. It's going to partly be because they understand how to manage risk and are disciplined about it. And I think it's partly because they're going to use information technology that's much lower cost and is much more extensible over time than the systems that are in use today.
Will insurers work with providers to institute payment provisions, and will they have any incentive to stick to the agreements?
Again, that's a great question. I mean, it's one of the real mysteries to me of our healthcare system over the last decade that health plans haven't reached out to more provider organizations, partnered with them, and created essentially provider networks of excellence. I think that trend is probably going to accelerate as the cost crisis that I described accelerates. It may be that we won't see this really occur until the reform issues around individual mandates and health plan medical loss ratios are finally settled. I think there's a lot of people who are in the health plan world who still don't think this is all going to occur.
And actually, with my apologies to the audience, we'll have to be selective in the few minutes we have left, and you have Dr. Kibbe's email up on the screen if you want to email him directly. Given the potential legal liabilities, wouldn't one security event in a healthcare cloud be fatal to the cloud organization?
I'm sorry, could you repeat that? Wouldn't what?
One security event in the cloud organization be fatal to that organization?
No. I mean, think about the enormous numbers of breaches of security that occur in hospitals and medical practices on a daily basis to now, and they certainly are not fatal. On the other hand, I do get the idea, and I think it's one of the reasons why, when I'm asked about organizations like Google or Microsoft or, having security problems, I bring up that issue that they have been dealing with this as a business liability for a long time, and they, one security problem isn't going to bring anybody down, just in the way Tylenol is still in the market, even though it was poisoned. But it's a good point in the sense that I think that these systems that I've been describing are, generally speaking, being run by people who understand the privacy rules very well, and the penalties they would pay for breaking them.
I'll ask one more question. Physician practices or hospitals and hospital systems are understandably apprehensive about investment in current EHR technology because of the significant unknowns around centralized HIEs versus the kind of web-based capabilities you're advocating. What criteria might providers use to decide when to pull the trigger on investing?
Oh, my goodness. That's such a complex
1 minute.
question. Yeah, I mean, the sort of blasé answer is, well, it's always the right time. I mean, you know, you're talking to somebody.
Or never the right time.
Osborne Computer in 1983 or 84, 2 months before it went out of business. You know, I will say, however, that one of the things I've said very recently is that this administration has dramatically increased the innovation that's coming into the health IT marketplace. That's very confusing for the consumers. So that it will take a couple of years before this all sort of settles out and some consolidation occurs. I think the answer to your questioner's question is, you know, when you're ready, pull the trigger.
Okay, well, thank you very much. And this has been a delightful discussion period as well as the opening talk. Again, this presentation and recording can be found at www.pcpcc.net/media. You saw Dr. Kibbe's email if you wish to continue the conversation. And our next webinar will be February 10th, 2011, 1 o'clock, a case study of HIT integration in the Adirondack Medical Home Pilot Project with Drs. Ruggie, Weaver, and Nasavera. So thank you all. It's been a great session.